Good evening, everyone. This is Dr. Damon Adams. Thanks for joining me and welcome to Making the Right Choices in Restorative Materials, Don't Follow the Herd, Part 2. I'd like to begin this evening with a couple of opening slides just dealing with disclosures. Then I'll review learning objectives and also the overall industry trends as they related to both Parts 1 and 2. In case you didn't attend Part 1, this will help get those of you that did not a little bit oriented as to what we discussed. We went over a variety of dental materials, including lucite reinforced porcelains, lithium disilicate, glassy ceramics, aluminum oxide, and layered zirconia the last time. And tonight we're going to focus primarily on monolithic zirconia, one of my favorite topics. Mention of any specific product names this evening does not infer endorsement by either Dentistry Today or me, and any opinions expressed are not those of Dentistry Today. As far as my professional financial disclosures, I have no paid or unpaid consulting financial relationships with any of the manufacturers of products mentioned in this evening's lecture, unless I specifically note it. And that is, I received an honorarium from Eva Clark-Vivenant for the presentation of this two-part webinar series. So our learning objectives for this two-part webinar were identify key trends in the use of all ceramics, review all ceramic selection and treatment planning principles, discuss monolithic zirconia restorations, are there going to be future challenges and solutions, and evaluate prep, build-up, and other considerations for modern lab fabricated restorations. There's been tremendous growth in all ceramic throughout the world. Multiple in vivo studies confirm lithium disilicate to be a very strong aesthetic and long-lasting material. The vast majority of published leaders, including the leaders that we publish in Dentistry Today, are using lithium disilicate as their go-to all ceramic. And they're using zirconia, as we observe it, selectively in molars only. Layered zirconia restorative materials are kind of a failure, success, a misunderstood story, as we went over in Part 1. Introduction of chairside in-office CAD/CAM zirconium restorations has taken place just in February of this year. New, more translucent zirconia products are being rapidly introduced. 70% of full-service labs now offer CAD/CAM restorations. And lab sales in monolithic zirconia, which is the focus of this evening, are increasing rapidly. Are there future challenges related to use, possible misuse, maybe overuse of monolithic zirconia full coverage restorations? What do you need to know? And there are changing practice and lab business relationship models, consolidation of practices, of course, corporate, DSO, and the laboratories are decreasing at a rapid pace. There were 11,500 labs in 1995 now to 8,000 laboratories currently, approximately. We went over also that, as you'll notice here, all ceramics, according to Dental Advisor, looking over a long span of time, was failing at a rate of about 3.6% at 10 years, which compared favorably, as did other studies I went over in Part 1 with PFMs. And then as we go further and further into the length of time these are in the mouth, fracture rates increase as a function of time. That really brings us to occlusion. Why are things breaking up in the mouth? Why is it a system that's unstable? And why are we treating occlusal disease? How are we treating it? Are we using bite splints? Are we learning how to equilibrate? Are we learning how to do these things ahead of our restorative work? Do we have dynamic and untreated disease after we place restorations? These are important questions. And a lot of the focus of the materials, how strong is strong enough, has gone towards occlusion. Fractures have been a big deal, and none of us want to have a restoration fracture. Do we have realistic expectations? Have we had those as new materials have come out? We build a material, we build it strong, we think it's going to work, and it fails. So we build a stronger material. It works. It works really well until the job gets even tougher, and then it can fail. Well, along came monolithic zirconia, first introduced in 2010. A very noted, very well researched one was put out by 3M called Lava. And in recent years, we've got the introduction, of course, of Lava Plus, which is a translucent zirconia. But many of these come out. One of the big names, of course, is Bruxer, introduced by Glidewell Laboratories. Now they're Bruxer Anterior. And Bruxer Now for chairside use, for those of you that have CAD/CAM equipment in your offices. Many, many names, as Rella Christensen told us a couple weeks ago at a lecture at Baylor University, or excuse me, at Brigham Young University. There's a name war going out there, and we have, for instance, Crownzilla. There are many names yet to come. Don't let them confuse you. There are different formulas. We'll talk about that in a little bit. An exciting single-visit chairside option for CAD/CAM users, in-office CAD/CAM users, was introduced in February, called CEREC Zirconia. We featured Dr. Michael DeTola, who's now with Sirona. He was with Glidewell Laboratories. And also, again, we featured Mike Scramstead and Dr. DeTola in another article, a follow-up article, just in August, this month. So if you have a chance, go to dentistrytoday.com if you didn't get the printed issue and take a look at this article. It gives the details of how these are made. The upshot of these are we've got much faster centering time in the office because it features dry milling, and that allows for 10 to 15 minutes centering time for crowns and only 25 minutes for bridges, so that's a real breakthrough. Are they the best looking? You be the decision maker in that. Are they good enough for posterior use? I think so. A lot of patients won't complain about that. I don't think it looks as natural, certainly as we would get with lithium disilicate there, or even a well-done PFM with layered porcelain or layered zirconia. But these are serving a purpose, and we're learning more and more about them. Great fit, great margins, and very functional. Let's go over the advantages and disadvantages of 100% monolithic zirconia. And at this time, we're not talking about the new translucent zirconia. We're going to kind of focus on the original zirconias that came out for monolithic use. Biocompatible, highest fracture resistance, minimally invasive occlusal reduction is required. Wear resistant, minimal opposing wear, excellent fit in margins, no metal color at the margins, any marginal work. You could probably cut the prep in your sleep, but chamfer preps are definitely the best. Conventional or resin cement. These require less time and labor to make, thus very profitable for the lab and hopefully more affordable for the doctor. They can appear opaque clinically, bare aesthetics, best for posterior. Of course, translucent zirconia is changing that game with the better aesthetics in the anterior teeth. Removal from the mouth, note this in the light purple, very difficult, depending on the technique and prep design. We'll talk more about that. Intraoral adjustments requires meticulous polishing technique. Low-grade degradation in the presence of moisture and stress has been reported with zirconia in the medical side of the house, but no clear evidence yet related to failure of dental ceramics has been shown. But we'll see with time. More long-term in vivo research is needed, really with zirconia in general. But we're getting there. We're starting to understand this material more and more as we go. Monolithic zirconia indications, posterior crowns in cases with limited interocclusal space. That's a very good one. Also, dark cores, endotooth, they have to be masked or covered up, although you can get some value shift depending on the thickness of the zirconia going over a dark stump, and it also depends on the level of how dark that stump is. Implant abutments is a good use for this. Good indication also implant retained bridges, Pretau implant bridge. These are fixed removable bridges that are entirely zirconia except for the pink porcelains used for aesthetic gingival areas. Fixed anterior and posterior bridges, also anterior crowns, option over implants. What about bruxism cases? It's kind of ironic we have one of the most famous ones called Bruxer. Well, the material is extremely hard, nothing like we find in nature. How much more is it than nature? Well, look at enamel and dentin. So we have to ask ourselves, when we look back at part one, and I talked about layered porcelain being the weak link, that really is the layering porcelain over zirconia or PFMs at about an average of 120 megapascals that can fracture under load, or where it's been maybe not adjusted properly or left high in occlusion. The bottom line is, in any system, the weak link will break. That's an engineering principle. The weak link will break. So my question is, as we go forward in time, and this will take a long time to find this, especially as it's been being done in vivo in all our practices, what's the weak link when you put a very strong material over a tooth? And let's say it hasn't been adjusted just right, where the patient has dynamic occlusal or parafunctional habits, and that's constantly being hit and moved on. What becomes the weak link? It's really the bone, the periodontium, maybe even the tooth itself. So it's going to take time to know whether this is really the smartest thing to use such an extremely strong material over natural teeth. So more in vivo studies are needed. When we look at our chart, and you'll remember this chart, those of you in part one, we want to go stronger as we go posteriorly and maintain great aesthetics as we go anteriorly in our treatment planning. And anybody who wants to take a look at part one, you'll see how we built this chart. And I won't go over it right now, but we have various materials going in these different zones generally. Are there exceptions? Yes. Because remember, we're looking at occlusion issues, we're looking at aesthetic issues, we're looking at the materials themselves and the patient, how they present. So it's complex, but this gives you an idea of where these can go. In my opinion, monolithic zirconia in the first molars and second molars can be a good use. Monolithic translucent zirconia in the anteriors only. In the anteriors only. Really, if we're going to build a case from bicuspid forward, in this zone here, as we mentioned, the layered zirconia is a great choice, and certainly lithium disilicate in this zone, in my opinion, still is more aesthetic than we can get from the translucent zirconia, even the latest, best ones. And of course, we're fighting some other challenges as we make monolithic zirconia more translucent. Cementation and bonding for monolithic zirconia. Conventional cementation, this is the same as lithium disilicate, as long as you have preps with adequate resistance and retention form, an axial wall height of 3 millimeters or greater, and a prep of approximately 5 to 7, 10 degrees at the most, or less. That's indications where you can use conventional cement, such as a glass ionomer or resin-modified glass ionomer. A less conventional, but considered a conventional cement might be Ceramer by Doxa as well. Resin cements can be used with these. We don't get true bonding, but we can use a resin cement and obviously an adhesive per manufacturer's instructions for the cementation kit or a universal primer, such as Monavon Plus by Eva Clark Vivanet. Monolithic zirconium oxide can be used for 3-unit fixed partial dentures. Comparing the two materials, the long-standing one of over 50 years of use, the PFM, to the 3-unit fixed partial denture out of 100% monolithic zirconia. PFMs have good to excellent aesthetics. It's somewhat prep dependent, and of course you can have aesthetic problems at the margin depending on the type of margin that you're dealing with and the lab technician is. Stress breakers can be done. That's particularly helpful in the mandible where we get some flex. In certain cases, that's a much overlooked design that needs to be considered, stress breakers. Any cement can be used. Fracture of layering porcelain and interconnectors is possible if they're not appropriate size. Comparatively easy removal, and again, 50 years of in vivo research, 50 plus years. Monolithic zirconia, when we compare it, fair to good aesthetics, better at the margins with less preparation, very good aesthetics in the anterior teeth when you're using the translucent zirconia, again, not as high in aesthetics as lithium disilicate, or even a layered zirconia anterior bridge, but it's getting there. Stress breakers are now possible. 3Shape and other programs and companies are moving to the ability to do stress breakers in these monolithic bridges when necessary. Any cement, just like PFMs, highest fracture resistance with less interocclusal space needed. So if you have an occlusal vertical dimension you can't open, these can be a good choice sometimes because you can, as long as you meet minimum interconnector and occlusal clearance standards, requirements, you'll be okay with these, something you want to discuss with your lab team if there's any question. Very, very difficult removal of 3-unit fixed partial dentures, again, because you've got those, in a lot of cases, pretty large interconnectors. We'll talk about that. Needed more long-term in vivo research. Fit and margins on these, excellent. Excellent, great fit and margins. Shade and aesthetics for the posterior, and again, we're not talking about the translucent, we're talking about the regular first introduced monolithic zirconias that are used in the posterior areas. Shade and aesthetics are excellent, or at least good enough to satisfy most of your patients. How does monolithic zirconia aesthetics compare with that found with the layered zirconia restorations? Well, if we look at 2 cases here on the models, this is the monolithic zirconia, not layered, just polished. And if you look at the layered zirconia case here, I think you can see that you get a lot more detail, a lot more natural appearing teeth than you do from just the monolithic zirconia. If we look at the next slide, you'll see one of these in the mouth, monolithic zirconia in vivo, and now here is a layered porcelain over zirconia, and compared side by side, I think you can all see a difference between how the adjacent teeth, the natural teeth, were matched with these 2 different types of zirconia applications. Some labs have, a lot of labs have done this, as a matter of fact. They try to help us, have the strength of a very strong material, and at the same time give us aesthetics. And before translucent zirconia was out, Orem had a very nice selection of different options, basic, plus, and ultimate. And what they were doing, that was in the different regions for both molars and bicuspids and anterior teeth. They were layering porcelain over the facial aesthetic surfaces and then polishing the zirconia on the occlusal and lingual surfaces. So you had your layering porcelain only on the aesthetic portions of these crowns. That still can be done and can still be a very beautiful option, by the way. So in 2013 to 2016, we've seen an absolute explosion now of translucent monolithic zirconia. Again, almost a name war going on. You have a lot of proprietary names in laboratories. So you have to understand, as I mentioned in part 1, the basics of materials. Know your materials like lucite reinforced, lithium disilicate, aluminum oxide, zirconium oxide, monolithic, zirconium oxide, monolithic, translucent. These are categories of materials, and all the names just are coming at us a mile a minute, but it's better to learn them by categories. Now, the goal of the translucent zirconia was to create a restoration that mimics or matches the optics or the aesthetics found in nature. That's, of course, been their goal with many materials that are manufacturers. Porcelains, the translucency is determined by thickness of the glass, the size and shape, chemical nature, and number of crystals in the matrix. And with zirconia, translucency is determined by thickness of the zirconia, increasing the yttria oxide content with altering firing cycles, resulting in a higher number of the cubic, the more clear molecules. You probably know what cubic zirconia is, on a ring that looks like a diamond. As we go towards that more clear material, unfortunately, though, we get weaker. Decreased number of aluminum decrease, reduction in strength, impurities and structural defects. These all decrease, and decreasing these sources of light scattering increases translucency. Excuse me. Here's one of the first cases. In fact, it was the first case we published on a single unit translucent zirconia. This was done by a friend of mine, Dr. Lynn Boltzmann and Dr. Boltzmann Holt, and we're really impressed to see that, at least from the facial aspect, it did a good job, I think, of matching in with the adjacent teeth. So over the previous standard zirconia, if you will, before these translucent zirconias, that would be very hard to do on that bicuspid. If we look, however, at the occlusal view, and you focus in on this tooth, it doesn't look so hot from this angle, and especially if we compare it, look at the other side with a natural tooth. Does this look the same to you? Have we arrived? Have we found nirvana with translucent zirconia? I'd say not. Can we do this with the appropriate layered zirconia? Yes. Can we do it with lithium disilicate? Yes. Could we do it with a PFM that's appropriately and adequately reduced? Yes, we could. But I think you can see a difference. So we're not quite there yet. And again, if we try to get this way more translucent, do we weaken it to a point where we don't want to use it in a bicuspid setting? So those are all things that we are challenged with. This is a patient that was unhappy with the aesthetics of existing restorations, including the coloring and the black triangles. And we published this for Dr. Robert Ritter, who was our cover featured author, full cover author, in September. Just an excellent gentleman, great clinician, and I enjoy working with him. This case shows us something that's really important. First of all, just look at what was started here. Notice that the patient is coming in because of black triangles, because of recession. Now, I want to make a point here, because this is going to come back when we talk about cutting these off. It isn't just fractures, folks. Cementation failures are probably the #1 cause when you look in the literature for failures 6 months, a year, 2 months, 3 years out, 2 years out, 3 years out. Cementation failures, microleakage, recurrent caries, gingival recession like you see here, black triangles, the formation of black triangles, period problems. These are the #1 reasons, if you lump them together, that we have to remove most of the crowns that require removal. It isn't fractures. Fractures bother us because, you know, if you have one, it's one too many. But when you really think about it and you look at all the practices collectively, these situations like this far outnumber the fractures that we've had over the years, and we looked at that in the literature in part 1. So the molars had to be moved into the position of the premolars. The molars were evident in the side views, so they needed to be restored. Unfortunately, a lot of times we take old PFMs off and it shows the dramatic reduction that was required when these were done, maybe over-reduction. That's debatable here. We don't know the situation. Often when we just take crowns off and look at somebody else's work. In RMGI, resin-modified glass ionomer cement was used here. It was Reliance Luting Plus by 3M, peeled off easily and gives us a really nice result. And one of the reasons I show this is the first large monolithic zirconia case that was published in Dentistry Today. Dr. Ritter did a beautiful job with it. I would ask this question: if someday these had to come off, and I know he did a fine job and the chances are it's not going to happen very soon, but if they had to come off, what would those be like to take off? But you can see that the translucent zirconia, certainly in a large case, not a crown here or there, maybe not just a central or a lateral or 2 laterals. They look very nice in this situation, and Rob did a great job. So that was our first Lava Plus high translucency zirconia published case. Now, what are drawbacks or cautions with the new translucent zirconia materials? Well, I mentioned it before, lower strength and fracture toughness. You're going to hear fracture toughness more and more as we go forward, and not just by axial flexural strength. It's down from 1,000 megapascals to 600 to 650. You'll see a variety of megapascal strength ratings for these translucent zirconia materials because there's so many different formulas coming out. There's almost a complete loss of transformation toughening. What is that? Transformation toughening is the slight 2 to 4% expansion of zirconia that stops crack propagation in the original formula of zirconia. There is gentle handling required for these. Occlusal adjustments, you've got to be careful with these. Again, you have to polish them meticulously. Use the right burst, use light touch, lots of water when you make the occlusal adjustments. Don't use an old burr. Don't bear down hard on it. Do it gently. And if you're cutting an endo-access opening through these restorations, you must be very careful. In my opinion, if an endo-access opening has to be cut through a translucent zirconia material, I would replace it. I would replace it. No matter whether insurance covers it or not, I do it as a courtesy for the patient if it happened within the first 5 years. There's a 2% fracture rate after chairside adjustments reported in one study of 285 molar crowns at 8 months. That was my clinician's report and reported in July 2016. Speaking of clinician's report, Rella Christensen has an excellent short. You're looking at the whole article, a one-pager. We love these focus-ons on translucent zirconia. And all our authors, whatever they focus on, I ask them, let's focus on salient points, the most important thing the practicing clinician needs to know. One of the points in this was, will translucent zirconia serve better clinically than lithium disilicate? Because I hear a lot of doctors asking, why shouldn't I just do everything in monolithic zirconia? It's stronger. Why shouldn't I do that? Well, here's a good reason. Currently, no one knows the answer to this question with translucent zirconia. Although the translucent zirconias have flexural strength that's twice that of lithium disilicate. The clinical significance of this difference is in terms of less breakage and greater longevity is unknown. And in fact, if you look at the science behind it, a lot of these translucent zirconias can have fracture toughness at, or it could be even less, lithium disilicate. So these are things we have to learn and pay attention to. Have our laboratory and our manufacturer partners help us understand these things before we just start putting a bunch of materials in patients' mouths that we don't understand. Are there cautions to consider when selecting a translucent zirconia brand? Rella says yes. Many dentists and laboratory technicians are unaware that zirconia formulations from various sources differ. They differ in a lot of different ways. And any one of those factors can start to affect your clinical durability and safety of the product. Dentists should ask their laboratory technician to include the brand name and company name of zirconia used for the restorations. And because we're legally responsible, we're the ones who are putting it in the patient's mouth, we need to enter that in the patient's record for legal and ethical traceability. We need to make these decisions with a lot of cerebration. Advice, and I would include this as my advice as well. I've said this many years in consulting between dentists and laboratories, which was something I did for a good number of years. Dozens and dozens of laboratories I've lectured at. Stick to any material, not just zirconia, from known dental companies and labs with good reputations, solid reputations in dentistry, despite higher costs. It might cost a little more. It's no different than anything else in life. But it just might last a little longer if we get the right material and it's used appropriately and made with quality. But we have to start with quality material. What about wear of zirconia? Let's shift gears here a little bit. If we compare glazed zirconia to polished zirconia, and I think many of you know this by now, but here are the studies that have proved this. Polished lava zirconia is very wear resistant, but it also preserves the antagonist best. If we put glaze over lava and then we put glaze over, say, Emax, they become the same. The study just then shows that glaze will wear the same. So we want to know what the material itself does, because lithium silicate can be used without glaze in occlusal areas, just like zirconia can. Here's another study that very well shows polished zirconia was gentler to the enamel antagonist as compared to a glazed surface. Another study, lava zirconia was equivalent to gold. If we compare across chart here, lava zirconia polished, equivalent to gold. But look what sits on the far left, right over here. You'll note that's lithium disilicate. And we talked about this in part 1. Several studies in part 1, including the one I showed you at the University of Alabama. It notes that lithium disilicate exhibits less wear, the antagonist enamel, than both gold or zirconia. So if you want the very best wearing, this is still our choice right here. Although, let's not kid ourselves. This is excellent wearing when you can compare to gold. Okay? Varying clinical techniques. What's the standard of care in North America? Do you do laboratory occlusal adjustments? You know what? Even using those clap devices doesn't help us, certainly with occlusal adjustments. We see a lot of these come in the lab and they say, you know, give me 16 shim stocks. In other words, open it up in space and then let the tooth drift into occlusion and maybe rotate and change the occlusion of that patient. That's not the way to do dentistry. Teeth are meant to have contacts. That being said, even if you use a semi-adjustable articulator, or for that matter, a fully adjustable articulator, you'd still have some occlusal adjustments if you're honest. That's just the way it works. And in what percentage of cases? Well, the vast majority of dentists are doing occlusal adjustments very frequently in their practices. That's just dentistry, because a lot of things can happen from the impression through the laboratory back into the doctor's hands. Also consider how many clinicians currently are employing full polishing sequences. We talked about that in part 1. Very important to follow every step with these. Every step. So with monolithic zirconium oxide, we want to use a fine diamond, new or like new diamond, and water to adjust the occlusion, keep it cool. If we polish zirconia dry, all my laboratory friends say that's the best way to do it, and it is. Polish it dry with the polishing tips. It will polish faster and easier that way. There are a variety of kits we can use. I'm not going to recommend any one kit. There are many good kits. You can make your choice out there, whether you use a kit by Comet or clinician's choice. It doesn't matter who it is. Do follow your instructions, though, because some of these kits may not be designed yet to polish zirconia. So you want to make sure that, again, you're looking at the material you're using in the mouth and matching a kit that's going to polish it. Well, here's an interesting in future in vivo dilemma. This old PFM bridge, it was leaking. This was intact and well cemented. And in order to get it out, to replace it with this full zirconia bridge, all the doctor had to do was make a slice. Take an old enamel hatchet and just go, and there it comes right off, very easily. Now this one's being cemented in adhesively with resin cement. If someday this microleaks or this one microleaks, all this has to come off again. Is this going to be easy like this one to take off? That's my question to you. And how thick is that zirconia? Well, when lava was first introduced in 2001, in fact before it was introduced on the floor of the Chicago Midwinter Meeting in 2001, as I was watching this material be worked with in the laboratories, I thought, you know, we're going to have some problems with this. So I started gathering burrs, lots of burrs. And this is a video that you won't see tonight because we forgot to get the file into it, but we'll handle this anyway. We started doing 10-second cuts. As we did these cuts with a brand new burr in full water, we noticed when we turn the lights out, it produces a little bit of light right there. Does anybody know how warm that is? Is it hot enough to kill nerve tissue? Do we need water? Oh, you're darn right we need lots of water because it's very hot. That when water is shut off, it's instantly too warm for the pulp, okay? Especially if you're on a vital tooth. Extremely hot. Now, thermal conductivity for zirconia is at the bottom of the list here. Its ability to transfer heat is very low. So as long as you have water, that's the clinical tip here. Lots of water. Make sure they're not testing your fire hydrants. Make sure that you don't have those air blips in your line. You've flushed it out and you've got a lot of water running. That's what you want to have when you cut these out. We'll get back to the burrs you cut them out with later, but I want to show you the history of what I learned. This particular burr, I was told, would go through this coping like a hot knife through butter by the representative that sold it to me at the time. That's a 10-second cut you see there in that coping in about a probably 5/10 thick coping. That would take me about 10 years to cut that coping off if I had had to do that intraorally. So what I did was we started taking just all these different burrs. We didn't know at the time. This is in 2001 because we knew, because the number one reason that things come out and have to come out of the mouth is not related to fracture. It is microleakage and cementation failures and recurrent caries, all those things I mentioned earlier. We got to know how these things are going to behave. So we tested burr after burr after burr. All these are 10-second cuts just to see relatively how fast they cut. Now imagine cutting this one out of the mouth. Let's say we're adhesively cemented or glass ionomer resin modified, and this abutment walks off. Can anyone imagine that happening? Sometimes that happens with these. Again, a lower mandibular bridge and flexure that happens in the mandible. Next thing you know, this walks off, the cement breaks, microleakage, these two are in, and we've got to cut it off in multiple places. That's not an easy job. If it was a PFM, piece of cake. But these materials like zirconia can present a challenge to us. Now remember, this is with layered systems, copings at only 4 to 5/10, and interconnectors at the standard minimum of 3x3 or 9 square millimeters for the fixed partial dentures or bridges. So this begs the question, what's underneath that crown? Let's say it's a case that comes to you from another practice that was placed 3 years ago. What are you going to face? How much time should you allow? How thick is that? Well, it really has to do with what's underneath those monolithic zirconias. How does the prep affect the thickness of the zirconia? Well, it directly affects it. Let's look at some real cases in U.S. laboratories. That's going to be a very thick zirconia crown, isn't it? Look at the over reduction of the margins. You don't need that for a zirconia crown. But this is what we're seeing. Look at this one. Look at that one. That's all going to be taken up. These are all zirconia crowns being done on these. Now remember, it was very difficult to cut a 5/10 coping. How about this? If it comes into your practice and has to be removed, or an endo-access opening even put through it, and then removed. Consider also fixed partial denture interconnectors. We're seeing them being measured at 4x4, 5x5, up, large interconnectors. So here's the important thing, and it wasn't stressed enough in the beginning when these were introduced. Minimum prep reduction for monolithic zirconia. For posterior teeth using a zirconia such as the very popular Bruxer, 5/10 minimum. Up to 1 millimeter anatomic reduction. Now it has to be 5/10, no less, but that's the minimum. If we look at anterior teeth, this is standard zirconia now. This is not translucent. We'll get to that. We're at, excuse me, my apologies. The previous slide. This is the standard Bruxer zirconia at 5/10 to 1 for posterior. Anterior teeth, using a translucent zirconia, such as Bruxer Anterior or Lava Plus, 8/10 to 1.2 millimeters. And again, we want to make sure if you're in functional areas, you probably want to be approaching 1 millimeter because reported again at Brigham Young University when I was lecturing with Gordon and Rella Christensen, they made a real point. Rella made a very good point that they're seeing fractures early on in translucent zirconia that's not thick enough in these functional areas. Again, a monolithic zirconia crown prep. Rounded line angles, much nicer looking prep, but too much room. So we got some data provided by the Apex Dental Milling Center. I requested it. I had them look at 100 randomly chosen cases, completed posterior full zirconia restorations. I want to see how thick these are. The range was 1.5 to 5.5 millimeters. The average thickness was just over 3 millimeters. Folks, this on average is 6 times the minimal reduction or 3 times the maximum recommended reduction of 1 millimeter. 6 times the minimum reduction needed for zirconia posterior restorations. It's very revealing. 100 random cases. And we're seeing this in the dental laboratories everywhere. We're cutting away too much of the tooth. At the same time, don't forget, we don't want to make these too thin either because we invite fracture even in zirconia, even regular zirconia. If you go below 5/10, that's not a good thing, and I'll show you what that does a little bit, the principle there with lithium disilicate in just a minute. Lingual thickness of 50 randomly chosen completed anterior full zirconia restorations. The range at 8/10 to 2.2 millimeters, and we found an average thickness of 1.4. This is on average 3 times the minimal lingual reduction required for zirconia anterior restorations. So what this data shows us is that overall, we're prepping too much, okay? And that's a misuse of this. That's not a good monolithic zirconia prep. That's too much tooth taken away. And in this day and age, when we're trying to be more minimally invasive, we need to use minimally invasive materials in the appropriate way. So all monolithic zirconia preps should be as minimally invasive as we can get them in design. Now, we may thicken something if we've got an occlusal issue, if we, where we have parafunction, patients not wearing their bite guards. I'd go more towards the 1 millimeter for the monolithic zirconium oxide than I would 5/10. And again, if you have 4/10 in functional areas, a thin spot, or you've adjusted it down to 4/10 or 3/10, you're inviting fracture, even in these monolithic zirconia crowns, whether it's the translucent zirconia or the regular zirconia. So these are all things we have to be very thoughtful about. We need to know our minimum occlusal anatomic depth for posterior preps, 1.5 to 2 millimeters for a lithium disilicate layer, 1 millimeter for lithium disilicate monolithic to 1.5 millimeters. And that was just revised by Ivaclar-Bevan in 2016. This minimum is somewhat reduced, but I'd be careful of that again, depending on the patient and where you're at in the mouth. I'd go a little bit thicker. Zirconia layered at 1.5 millimeters minimum, and then of course the most minimally invasive material for use maybe where you don't have as much occlusal vertical room, say in a second molar. Great to use the zirconia if you don't want to use gold, and gold is still an option, by the way. So those are your requirement reduction requirements, and they need to be known by everybody what those ranges are. Now, how do we stick to those? I'll talk about that in a minute, but I want to make the point again about taking enough off. If we look back up to lithium disilicate, how much load can it take? And this was an excellent study done. It was, I think, paid for by Eva Clark-Vivenant on their lithium disilicate material Emax. 4 groups were tested, thickness of 1.5 millimeter with conventional cement, reduced thickness, and then thickness of 1.5 millimeters with adhesive cement, and then the same cement used in a reduced thickness. Load to failure was measured, and this is the result. If we look at the conventional versus the adhesive cementation, obviously the reason that we recommend adhesive cementation with lithium disilicate as the go-to way to cement it in whenever you can, you get more strength. But more important here, and what I'm showing is, look at 1.5 millimeters conventionally cemented compared to the strength, load to failure strength, of just 0.8. Dramatic decrease in strength. The same thing is applied to the adhesive. Even though we get more strength than any other method here, we notice that we get a real drop-off in the load to failure by reducing that material thickness. So that's an important thing to remember. But we don't need 3 millimeters of material. That's kind of the point I'm making. So we need the right amount, the right amount. How do we determine and really predictably get the right amount in our preparations? Well, it's an old-fashioned thing called in-cutting reduction burrs. Why more dentists don't use these? I don't know. Those of you who do, terrific. Congratulations. But realize these need to be chosen not by kit names, lingual depth, facial depth, whatever, but by their dimension. So monolithic zirconia, monolithic lithium disilicate, PFMs, these all are keyed down here. You'll see this if you want to review this part later. What we're doing is choosing the appropriate end cutting burr for the dimension that we want occlusally. I think that's the most basic way I can put it. Different burrs are available. This happens to be a kit by Dr. Athos Koumidis by Meisinger, and I'm sure you may have your own favorite occlusal reduction burr, but if you don't, find one and make it your favorite, because these are very, very helpful. The kits are made in different dimensions. You need to find the dimensions that are appropriate for the material selected. So whether we go 0.5 millimeter or 2 millimeters in a posterior occlusal reduction burr depends on the patient diagnosis and the restorative material chosen. If I was going to do, say, lucite reinforced authentic or Impress aesthetic here in these bicuspids, I might choose to go 2 millimeters reduction. If I went with lithium disilicate, I could go 1 to 1.5 millimeters, depending again on the patient. Whether you have an open or closed OVD, these are things you have to pay attention to. A previous core, restoration. Again, is it treated or untreated occlusal disease? Is there parafunction? This is one method that I have taught for years in hands-on courses I've done on these prep basics, and that's to take from mesial to distal, take the groove out, bury the burr, go out the facial and the lingual groove, and then kind of like a wagon wheel from the center, leaving these little islands right here and here to make it a little easier to slice through with less tooth structure. You do the same thing on bicuspids. This isn't rocket science. This just helps direct you and keep you in line with anatomic reduction. Dr. Jack Griffin, who's going to be our cover clinician in November, as a matter of fact, he does it a little different. You notice I go out between the cusps, okay, and he likes to go out right through the cusp and then the grooves, and he goes ahead and puts it completely down through the whole length, mesial, distal, does a slice right there at that point. It's a different way to do the same thing. The bottom line is he's staying oriented in space. That's what we want to do. Then we connect those occlusal depth cuts using our tapered diamond, and we do it again thoughtfully, not creating a flat top, not angling the burr like you see here where we get over reduction and under reduction at the same time. We want to thoughtfully put that in the inclined plane direction. If we're in a core, we would do the same thing because we want anatomic reduction. These preps are going to look a little strange for those of you who aren't used to cutting anatomic reduction, but think about we get great resistance, retention form, and we don't over-reduce in certain areas and under-reduce in others, and we give the laboratory or our designer for CAD-CAM the depth that they need to make the material that's appropriate. Then we place our depth cutting lugs, half the tip width of the burr. This particular burr, the 856-01H, great for posterior teeth. It cuts a 7/10 chamfer exactly if we use it with appropriate magnification and watch how we're cutting it carefully. Let's digress just for a second. You know, we've gone through here and cut the interproximal slices. Iatrogenic damage to adjacent teeth during proximal boss preparation was studied by Lucy et al. And published in the Journal of Dentistry back in 1998. And damage was found to 78% of those adjacent tooth surfaces when they were conventionally repaired. If we look at this case I published, a beautiful case, done just the way we just talked about with the acus cometus reduction burr by Meisinger. Look at this, beautiful job, beautiful control, nice prep done. Look at that, chamfer to die for, but look at something else here. Guess what? Oh my gosh, and on both sides. Now if that was just composite or amalgam, we could polish it out, sand it and polish it out, and probably be okay if we didn't take too much off. But in this particular case, wow, I mean really, probably we're talking about replacement of this crown. We've damaged that. So that was published case. This happens. It happens to the best. It happens to the leaders. So go ahead and remove that pockmark you made if you can, and make it easier on the laboratory technician, and smoother to floss, and try to stay away from damaging adjacent teeth. So now do we have adequate reduction? Well, we used the burrs, didn't we? Well, that still doesn't, we still want to verify. It doesn't tell us we nailed it from a technical standpoint. So we can use occlusal reduction rings by clinician's choice. You can look those up online, flexible clearance tabs by Kerr. You can order those from most of your suppliers. They relate in color to the thickness, 1.5, 1 millimeter, 2 millimeters. This is one of my personal favorites, Common Sense Dental. It has ink on it, so wherever it's left a little high, you can go in and just reduce that spot that's high. It will help you identify the high spot. Last step, of course, with all the all-ceramics, and quite frankly, this is good with all your restorations that are fabricated, round those axial occlusal line angles. Then that's a completed chamfer preparation. So I hope there's some tips in there to help you cut these anatomically and predictably. Again, you'll note it doesn't look like a flat top. There are hints of the cusps still left there. How about placing anatomic cores? Well, look at this case. Imagine if a zirconia core crown was done here, no core was placed chair side, and you had to cut that puppy off. Oh my gosh. Well, is there a way to place anatomic cores? Maybe using things like injection molding by composites. Well, I published Dr. Jeremy Rose's and William Bartusiak's article in February 2014, and he was an attendee at a class shortly after at Chicago Midwinter when I lectured there. He was happy to see his lecture, or his case, and the promotion of this article. I'd like you to read it if you get a chance, February 2014 at dentistrytoday.com. It teaches, as I told the class and told him, it teaches very, very appropriate reduction for lithium disilicate for zirconium oxide to build anatomic cores. Again, look at this case. No fractures. That's why all these are being removed. It's recurrent caries, micro leakage to drive that point home again. A wax buildup is done and cut back in the laboratory, and then applied, in other words, transferred into the mouth, and the preparations are finished. To go through in detail, this is the same article. Again, these have to come off. Before they come off, the steps are to take a upper and lower alginate substitute impression, nice accurate impression, have the laboratory technician wax up in full. By the way, this could be done digitally as well. Put on an articulator, a semi-adjustable articulator to get our proper function and contours on the lingual side. Of the full contour wax up, a addition silicone putty index is made, and this is made in a Siltec putty by Eva Claire Vivinen. It will be a different color than the one you're going to see of the cutback. This is of the full contour that's going to be used for the temporaries. Now the technician cuts the wax back, in other words, does the preps, okay? And that is just beautiful core shapes that are going to be transferred into the mouth. Those are captured in this case, a different color addition silicone putty. The prep work is done, endodontics, whatever needs to be done. Again, amazing what goes on underneath these and why we have to cut a lot of crowns off sometimes, huh? Once the teeth were cleaned, adhesive was applied, all bond 3 by Bisco, and then the crown buildup and matrix was filled with a dual cured resin core material. In this case, it was Corpus 3 by Denmat. Small amount is syringed into the preparation. You've got to be careful not to put too much in the stent because you've got more to clean up. This is after it's transferred to the mouth and ready to finish up the preps. So the importance of this is that the technician then can help us control those cores and then ultimately the thickness of the material appropriate to the material we select. Back to cutting off. How would you like to cut this case off? And this puppy had to be cut off. We're looking at splinted units, all splinted, not here at the midline, but splinted, full zirconia. Imagine. That might have been better put in with temporary cement and removed once a year and re-cemented, because that would take dozens of burrs and hours to get out for most clinicians. And you don't know how thick it is. But believe me, in this case, we knew it was thick. So they developed Z-burrs, a lot of different ones out there. They cut longer. They don't necessarily cut any better or faster. You don't want to put a lot of pressure on the burr, lots of water, let the burr do the work. It is definitely a recommendation to get one of these kits. Any of them work very, very nicely. You can kind of choose and do your own tests to think maybe to determine which ones work best for you. Some of the kits come with polishing tips in them. Some of them with the cutoff burr, but you're going to need way more than one cutoff burr, as you see, for instance, in this cut if you run into some of these cases. You might consider using disposable burrs. I learned this from Clinician's Report from Gordon Christensen. The ZR cutter, Neo Diamond microcopy, less than $2 for that burr. Same thing with the Crosstech diamond burr. And you can change these burrs frequently. That's the thing. Let the burr do the work. When you see it's not cutting well anymore, just get rid of it and put a new one in. That is an advantage of these disposable burrs over burrs that can cost $10, $11 each. It might take you a dozen burrs to get a bridge out, or maybe 15 burrs to do it efficiently. And when you cut through these and you're cutting off a vital tooth, again, lots of water, and pay attention because it's hard to tell where the tooth begins and the restoration leaves off. You'll end up with great big notches in natural teeth if you're not careful, because you'll jump through. So it has to be done very, very carefully. And again, don't forget that heat. With vital teeth, lots of water. This is a case report. Diagnosis and treatment planning was done, and we published this in Dentistry Today. I published 3 cases, 3 different articles now on this topic. You'll see what it is in a minute. I'll leave it as a little bit of a surprise. It's a 59-year-old female patient, and she presented with a pained biting in her lower right quadrant on this crown. And it turns out it was a monolithic zirconia Bruxer crown. It had been submitted about 6 months previously by another dentist, migrated to the office, and now the pulp is necrotic, and root canal therapy is indicated. What do you do in this case? How do we get that crown off? What are our treatment options? Well, we could cut an access opening through the crown, do the root canal, then restore the access opening with composite resin. And again, don't forget what I said. It's very important to know that zirconia can fracture. And depending on how carefully we go through that crown and do that access opening, you can have microfractures that exceed the ability for that self-mending through transformation toughness to occur. And, you know, maybe they end up on a ski trip and they're out there 3 months after you cut an access opening and you put that composite on, and now their crown breaks. That's why you heard me say earlier, I recommend you just replace the crowns if you have to cut an endo access opening. The second choice would be temporize the access opening, replace the crown at a future date. And again, that would be my recommendation to get it done as soon as possible, replace the crown. Or we could simply remove the crown in one piece, do root canal treatment, and then re-cement the crown. Now, if any of you have been awake this evening, you'd be shaking your head right now saying, what do you mean remove the crown in one piece? You've just sat here telling us how difficult these are to get out. Well, they are. And if you can't do the following technique, you're still going to have to go the old-fashioned way. But this is the exciting news if you own an erbium YAG laser. That's another powerful mouthful because these are not cheap. But if you have access to one, maybe a periodontist in your town, maybe somebody you can create a contract with where they agree, not to steal your patient. You literally have it in writing, and they charge a specific fee to try and take the crown off. Now, they can't guarantee it, and you can't guarantee this to the patient. It doesn't always work. But a good number of these, as you'll read in the articles that we publish, can be removed using the PowerLaser AT laser system. And there are specific laser parameters for each of these different materials. It's all different, whether you're cutting off Impress Aesthetic or Emax, lithium disilicate, or you're cutting off zirconia, or say a straight porcelain jacket crown, felspathic jacket crown. You're going to have different laser parameters. If any of you are interested in doing this, I'm happy to take an email at damon@drdamonadams.com. That's Damon, my first name, at drdamonadams.com. Again, damon@drdamonadams.com. There's no period after doctor, by the way. And I will get you in touch with Jeff Kranska via email, and he can share these latest laser parameters. They have changed a bit over time, not much, but they kind of have nuanced these since we first published this. The latest article he did, I'll show you that article too in a minute, was done in March of 2015. The clinical protocol in this case was to deliver local anesthetic, 1-carco 2% carbocaine in this case, and it was given for the root canal treatment, not for the crown removal. Air water spray with a vacuum tip to remove water, excess water is used, and slow movement of that energized tip to increase the power density. You start on the occlusal surface and just slowly paint back and forth over the occlusal surface, the lingual surface, the facial surface, and only the erbium YAG laser was used with the tip in near contact with outer surfaces of the monolithic zirconia crown, by the way. Erbium YAG laser, it's important. You can't do this with a diode laser. It has to be an erbium YAG laser. In less than 1 minute, the crown popped off. There was no cement left in the crown. You'll see where the cement is. It's on the tooth, okay? And will this work, for instance, now we come back to the thickness issue. Will this work when we're dealing with crowns that are on average zirconia crowns at 3 millimeters? Probably not. So it's an important reason to keep these, another important reason to keep these at the appropriate thicknesses. I've talked to Dr. Kranska and Dr. Glenn Van Az on this, and they feel that probably up to a couple millimeters we're okay, but definitely when you get too thick, particularly in zirconia, which is a more opaque material, it's a little bit of a problem getting that energized. Root canal treatment was done in this case. And of course you can see no excess opening had to be done through a crown. It was off, and then the crown was simply cleaned up. Everything is and your steps of cementation are the same as always. You've got to clean that internal aspect. In this case, it's wise to sandblast the internal aspect of the crown. I don't normally recommend that with zirconia. If it's been sandblasted in the lab, it doesn't need to be sandblasted again in the office, but in this case it does. And of course, the prep should be cleaned up very, very well and re-cemented in place. Another important thing to note for those of you who maybe have an erbium YAG laser or want to try this, don't do it. I recommend do not do it until you read the articles by Dr. Kranska and Dr. Van Az. And if you have any questions, as I say, they're the ones to contact. They do have their contact information also in Dentistry Today in their articles, so you're welcome to contact them directly from there. If you have a problem with that, then you could use my email address and say, hey, I can't get a hold of Jeff or Glenn, could you help me? I'd be happy to help you. So removal will not work in restorations with endo-access openings. If there's already an endo-access opening, it eliminates the photoacoustic effect, that's the photoacoustic streaming effect that interacts with water molecules and gets these to pop off. It does not burn the teeth, by the way. A lot of people ask that. Doesn't it burn the teeth? No, not if the correct parameters are used. Not at all. Do this on vital teeth. So this is the lineup of articles. The first one was written by Dr. Glenn Van Az in September 2012, and the second one by Dr. Jeff Kranska in 2013, and then an update. And by the way, he's active on a blog and in our Dentistry Today website with some current cases. Highly recommend you read it. You might want to just start with this latest one in March 2015. So a really cool way to get those off. Well, we're a little bit early, but hopefully we'll have some time for more questions because I'll bet I sparked some. I want you to know that I'm very proud to be associated with Dentistry Today. People think that print is dead, and here's my friend David. He's in his pool, and that's pretty hard to do on your iPad safely. And you certainly don't want charger cords attached. So the print edition has its uses in boats and pools and all kinds of things. We hope you read it. We also have the digital edition as well. And I would like to take this opportunity at the end of two-part seminars. We've got a lot of people watching. We have 284 attendees. We welcome new clinical authors. If any of you are interested in contributing, again, you can email me directly, and I'll get you in touch with our editorial coordinator. We'd love to have contributions at Dentistry Today from new authors. So it's been really great having you with me this evening. I want to thank you for your gift of time away from the chair. And my favorite way to teach is with you in my lecture face-to-face. I hope to see some of you. Identify yourselves if you see one of my lectures, and we'll cover a lot more things than we did in these two.